I'm Dr. Max Gomez, and I'm at Englewood Hospital today. You know, if you ask most women what cancer they fear most, chances are they'll answer breast cancer. And that's for a good reason. Breast cancer affects a woman's sense of their femininity, but it's also because there are more than 240,000 cases of breast cancer diagnosed each year, and more than 40,000 deaths. But we know much more about breast cancer, how to detect it earlier, what it is, and how to surgically treat it better, with fewer disfiguring operations and better reconstructive techniques. That and much more is what we're going to discuss today with our panel of experts. And let me introduce them, beginning here. First of all, with Pat Mazzola, who's an advanced practice genetics nurse. Welcome. Dr. Miguel Sanchez, who is the chief of pathology and is also the medical director of the Cancer Breast Care Center, correct?
Correct.
Dr. Merle McIntosh, who's the chief of breast surgery here at the hospital. And we also have Dr. Jill Morrison, who is a medical oncologist. Welcome. So let's have a little discussion here, and let's start, Dr. Sanchez, with you, because what we start out with, let's start out with early detection, because we have all been told that that is the best way to find it, treat it at a treatable stage, right? But there's been some discussion and some controversy about mammograms and mammography. Tell me a little bit about mammography, because we still consider that the gold standard, but is that really still a good way for early detection, and does it really save lives?
It's absolutely a magnificent way for early detection of breast cancer. They have limitations. Patient's age, degree of fibrosis or thickness or density
of
the breast, and we have other tools. But mammography is still by far the most efficient way to detect early breast cancer. We have patient groups that we use MRI, magnetic resonance imaging, because of the density of the breast or family history, but still mammography is very valuable. The debate has been, when do we start to do mammography, when do we end to do mammography, and how frequently should do mammography. And we have our own personal experience and our own personal bias. There were studies showing that, well, it's okay to start mammography after age 50. Originally was women over 40 to 50, with what we call a baseline mammogram at age 35. We look at our cancers for a number of 6 months after the original recommendations was to delay the beginning of mammography until age 50. And we found out that we have followed that rules. We have missed 25% of our breast cancers.
So that's why we've moved it to an earlier age?
So at this point, we say, regardless of what the other places have to say, our own experience tells us in our patient population, the patients that we will lose or will miss the diagnosis for 10 years, it was substantially enough to actually be conservative and start earlier. As you say, the early diagnosis of breast cancer is still one of the major criteria for predicting the biological behavior of how the patients are going to do. Mm-hmm. The smaller the tumor, the better the prognosis. The earlier diagnosis, the smaller the tumors. So there are other factors about tumor biology, grade of the tumor, there are family history, there are other points, but still I think that the early diagnosis is still one of the major reasons the smaller tumors are detected by mammography better than any other means.
And we're going to get into some of these other issues about the molecular characteristics, hormone receptors, and so forth. But Dr. McIntosh, Dr. Sanchez mentioned the size of the tumor, that early detection generally means a much smaller tumor. What does it mean when it comes to surgery?
That is going to influence the way we're going to treat that patient. A patient with a very small tumor in a small breast is a good candidate for a lumpectomy. If there's a large tumor in a small breast, this patient may have to have a mastectomy. So if we can find these tumors when they're small, the chances of breast conservation would be much, much higher. We have a lot of other options, but again, nothing beats finding a tumor when it is very small.
And also, in terms of determining whether or not it's spread or the stage, how do we go about doing that during surgery? Do you normally take out lymph nodes to try to stage a tumor?
Yes, so for patients who have invasive cancers, we do a procedure called a sentinel lymph node biopsy, where we identify the first lymph node or the first group of lymph nodes in the armpit draining the breast. We remove those for testing. In the past, we did axillary dissections. We took out 20, 30, 40, 50 lymph nodes. Nowadays, we take out 1 to 5 lymph nodes, occasionally a few more. But the side effects, complications, and risks of that surgery we used to do in the past, much decreased now. So we do stage patients based on the size of the tumor and the status of the lymph nodes under the arm.
Let's explain that just a little bit more, because as you said, an axillary dissection in the armpit where you would take out virtually all of the lymph nodes there, that increased tremendously the risk for angioedema,
Yes,
the big swelling of the arm on that side.
The condition called lymphedema used to be extremely common. We do still see some lymphedema with the sentinel node biopsy, but it's less than 10% compared to 20+% we used to see with the axillary dissection. So with this more limited procedure, we're actually staging the patient even better, because if the pathologist gets 2 lymph nodes, they can look at 2 lymph nodes very thoroughly, as opposed to trying to look at 50 lymph nodes. So we're actually getting more information from 2 lymph nodes than we probably got from 20.
And in pathology then, you're only having to look at 1 or 2 nodes instead of trying to look at 20 or 30 nodes, which makes it much more like trying to find that needle in the haystack, no?
That's correct. Our pathologists and most pathologists worldwide look at every single area under the microscope, and if you're looking at the areas from 2 lymph nodes, you obviously can do it a lot more efficiently and look more carefully and completely than if you have multiples of that number.
Right. Now, Ms. Mazzola, tell me, cancer is fundamentally a genetic disease, right? And we hear a lot about the breast cancer genes. So I think a lot of people think, well, I don't have a BRCA gene, a BRCA1 or a BRCA2. It's actually a BRCA1 or 2 gene mutation. Everybody has the
Right,
BRCA genes,
exactly.
right? So how do you explain to women what it means if they don't have it, what it means if they do have it? You've got a lot of explaining to do, because I think most women obviously don't know a heck of a lot about cancer genetics.
That's very true. Most people don't know a lot about cancer genetics, and the most important thing we think of it is it's not just genetic testing that we do. It's really counseling about cancer risk assessment and genetics, because genetic testing isn't for everyone, and trying to explain BRCA1, BRCA2, and all the other genes that we now test for an increased risk for breast cancer really takes a lot of time. That's a very important piece of what I do, is evaluating people not only for their risk for the BRCA, but for other gene mutations.
And I think people think, well, there's got to be a test. You know, I'll either find out I've got the BRCA or some of these other genes. But really, what you do is much broader than that. It's counseling and family history and so forth. Tell me what else you take into account.
Really, the patient's readiness even to have genetic testing and to understand the information that we're providing. Each of these specialists have discussed what their role is. We really put all of that together, and that's part of the counseling and the cancer risk, is putting it all together. Just because you don't have a gene mutation doesn't mean you're not at risk for the cancer. A lot of cancers, we don't know what caused the cancer. What we're really looking for are those people that do test positive for actionable genes, things that we can do something about. And we all work very closely together in trying to get this information from the patient, from the labs, to the surgeons, to the oncologist, so they can make decisions for surgery, for management, for treatment. So it's not just genetic testing that people want to do, or just a lab test, or just a blood test. It's really much more involved than that.
Dr. McIntosh, then, speaking of these tests, some women get tested either because they've been told that they need to, or they have family members or whatever, and now they come and they say, I have this mutation. I want a mastectomy. I don't want to be worried about this as a time bomb. How do you deal with that, and how do you counsel women when it comes to that kind of surgeries, prophylactic mastectomy?
So for those patients who have the family history and now they're testing positive for a BRCA mutation, I think it's really wise of them to proceed with prophylactic surgery. It doesn't make sense playing around when you have this hanging over you. So we talk about nipple sparing prophylactic mastectomies with reconstruction. The patient will get to see a plastic surgeon and decide whether or not they want to have an implant-based reconstruction or a tissue flap where they use their own tissue. Nowadays we use a flap called a DIEP flap, where the skin and fat from the abdomen is used to reconstruct the breast. And the patients have an excellent cosmetic result with that procedure. They don't have to worry about having implants changed over the years. And it works out very well. Mm-hmm. Even with the implant-based reconstruction, with the nipple sparing, the cosmetic result is actually excellent, and the patient feels pretty good about what the result actually turns out to be.
It doesn't actually reduce the risk to zero, but it reduces it dramatically.
To almost
is that fair?
zero. We say there is a 1 to 2% risk of coming down with something. And the reality is we don't like to say zero for anything. Right. But
there's no 100% in medicine for anything.
There is no 100% in anything. However, we really are very careful in doing the mastectomy, trying to ensure that we leave no breast tissue behind. Mm-hmm. Actually, there could be a few cells left under the skin, and that's why we say 1 to 2% risk, which is down from 85% risk. I think that's a good.
And the bottom line is, if women so choose to have a reconstruction, they have various options and choices to do that, and generally will come out with a pretty good cosmetic result?
Correct. So I would say for the majority of patients who test positive for BRCA1, BRCA2 mutation, who are over the age of 40, most of them agree to proceed with prophylactic surgery. Mm-hmm. And I would say 95% of them will have reconstruction. Very rarely would you have someone having prophylactic surgery and not having reconstruction. Mm-hmm.
Speaking of which, Dr. Morrison, let's talk about, all right, a woman has a BRCA1 or 2 mutation or a very high risk, but let's focus on the mutations that we know of. They decide to have a prophylactic mastectomy. My understanding is that it's also very important that they deal with ovarian cancer risk when it comes to this, and that gets lost a lot of times in this discussion. Tell me about that.
So Pat can talk to the issue of risk factors associated with the BRCA1 and BRCA2, but many of the different genetic mutations come with an ovarian cancer risk. The issue with ovarian cancer and pancreatic cancer is that we do not in the medical field have good screening tests for these diseases. So often, unfortunately, by the time we find the disease, it's in an advanced stage, and that's treated very, very differently, and it has a much poorer prognosis. So the best thing that we can do is remove the organ that is the possibly offending organ. Obviously, we need our pancreas. At this point in time, we don't have a complete pancreas transplant procedure, so that's not an option. But for the ovaries, for the woman who has already had her family, removing the ovaries, if you are BRCA positive or if you have some of the other gene mutations, that can absolutely be a life-saving technique before you even get a cancer.
So, Dr. Sanchez, there's also a lot of discussion about over-treating very early breast cancer. Yes. The so-called DCIS, ductal carcinoma in situ. It's not invasive yet. Some people even argue whether it's really cancer or not. Where do you come down on that, and how do you decide?
Yeah, there is no question about that. maybe about 30% of the patients that we diagnose of cancer right now have ductal carcinoma in situ, or as you say properly, in situ. That's a rather Latin way to do it. Anyway, so the problem that we have is we know that ductal carcinoma in situ is in many cases the precursor of invasive carcinoma. And until now, we really have no efficient and actually accurate mechanism to determine which ones are the ones that are going to be the bad guys, and we are the ones that are going to stay forever in the patient.
Right. So some DCIS won't go beyond that.
Correct.
Some will, but we can't really tell the
Well,
difference.
not yet.
Not yet. Okay.
But
Not yet.
it's interesting because we are in the process right now to work with the National Cancer Institute in a program that we are looking back in our cases and determine are there any mutations in the cells of the carcinomas in situ that in fact are going to be able to predict which ones are the guys that are going to behave as an invasive carcinoma or not. We are not there yet, but I tell you, we are very close. So there is no question that we are over-treating patients that they may not have developed dangerous tumors. And the good thing is that we are in the process to try to resolve that issue.
Dr. Morrison, I suspect that most women, also probably most men with any other kind of cancer, prostate cancer, I don't want to deal with worrying about it. I want this done and I want this out. But tell me now, we talked about depending on the molecular markers, the hormone receptors on the cancer cells, will determine what drug or drugs, combination of drugs you use there. But now the hottest area seems to be that everybody talks about is immunotherapy. Tell me a little bit about what that means and how that might be applied in breast cancer.
So immunotherapy is basically, the field of immunotherapy is using the body's immune system to fight the disease. And so the drugs that have been designed as the new immunotherapies stimulate the body's own immune system to fight against cancer. It has to do with the cells that are surrounding the cancers in general. And in most breast cancers, it has been a little bit disappointing immune therapy. What we have found that in what we call the triple negative breast cancers, the ones that don't have estrogen or progesterone receptors, and they don't have the HER2/neu status elevation, those patients do tend to be responsive to the immunotherapy drugs. So those are hopefully becoming more and more part of the regimens that we use. We do have open clinical trials in here and around the nation to look at immunotherapy in the triple negative breast cancer population. And that's a very exciting area of future treatment.
Let me put this question out to any of you who want to chime in, because it's a little bit of a hot button perhaps, is the question of, I'm diagnosed with breast cancer, a woman is diagnosed with breast cancer, and they go, well, I've got to go to New York City because that's the only place that will be able to treat my breast cancer. Is that true? Is that the case? And can you guys do that?
We don't think so.
I wouldn't expect
I trained as Sloan Kettering so many years ago, of course. And I can tell you maybe 30, 40 years ago was necessary to actually seek care in a institution that have the experience different than anybody else's. I don't think that's the case anymore. I think that the quality of all these oncologists and surgeons and geneticists, they have moved here. So in fact, they have provided us in the last 30 years with an increase in the sophistication of our studies, of our treatment. I think that the most important for a patient is to determine where I'm going to go to be taken care of. Just to look to see that wherever they go, they have the experience and they have a team of physicians that work together. I think that's to me more important than anything else. We just finished our breast management conference this afternoon, a few minutes before we arrived here to talk to you. And we decided 25 years ago when we opened our breast center that We were not going to discuss in our breast management conferences every week interesting patients. My philosophy was that for Mrs. Smith, her cancer was very interesting. No, no for other physicians, but for us. So we present any new breast cancer. 25 to 30 physicians are in that room, and we will discuss each patient what is the best management that take care of her problem or his problem. We present a male today as breast cancer. So in fact, your question is, do you need to run somewhere else to be taken care of? The answer is no. If you are able to receive quality of care in your own community and you have the actual family backing and the infrastructure to be able to support, your treatment will be better. So I really think that this idea of we have a lot of patients that I have to go and they come running back. They are put in a place in a room for 3 hours in one of the major institutions in the city, and we see them back very quickly.
You agree?
100%. I do find that we are confident in our abilities because we have the experience and we are comfortable discussing, questioning each other, questioning ourselves, reviewing literature, being on the cutting edge of literature. I think these are all things that continue to keep all of us on the top of our game, and that's very important for patients. I find that patients need to be comfortable wherever they are. So if they're getting a lot of family influence and people are saying, you really need to go, you need to go, I always welcome patients to go, get another opinion, make sure that they are comfortable with what I've said. And the majority come back saying, yes, they said exactly what you said, but I like it here better. It's more comfortable for me. This is my family. This is my area. I'm comfortable with these people. And we understand our patients. Yeah. It does. Yeah. You need to have a connection with your physician and your team of physicians. You need to have physicians who know what they're doing, but you also need to have that connection.
We really walk them through. We have Patient Navigator. All of these physicians and just about everybody else have all our cell phones. And if we have questions or concerns, so that they're not being sent in many directions, they really are only being guided in what we have perceived that they can actually handle at that time. So, and they really are walked through it, that our Patient Navigator is spectacular. She really reaches out to every single patient and to all of us to make sure that the patient, if they do have questions, if somebody is pushing them, what the patient really needs, not what we need or their family needs, but what does this patient really need? And because they really see us working together as a team, I think they feel really, really comfortable. That's the feedback that I get, that they know what the next step is. They're not being just released into the world of cancer and physicians. They really do know what the next step is.
One last question, the future. Where are we going? Hopeful?
Oh, extremely hopeful. I'm definitely a glass half full person, so I do believe that we're making huge strides in oncology, and working together as a team is, to me, the most important thing.
Where are we going?
Well, I know where we're going because I know where they're coming from. I reviewed, I'm a numbers guy, so I look at the numbers, and in fact, the mortality in our patient population for breast cancer has plummeted in the last few years. So we know we are going in the right path. I'm talking about breast cancer specifically, that when I look at the statistics 25 years ago, and I look now, our tumor size are decreasing, our patient survival is getting better, our therapy is getting less toxic. So I think we're in the right path, and as I mentioned before, getting involved in the genetic makeup of tumor cells of individuals is going to be the next step to actually that our patients with cancer, they're going to be like diabetes or AIDS, that they're going to, in fact, going to be managing these diseases, and they're going to become either chronic diseases or disappear.
Dr. McIntosh, I suspect you're still going to be in business for a long time.
Unfortunately, but it's an exciting time for breast surgeons. You know, the pendulum continues to swing back and forth. 100 years ago, 70 years ago, everybody had a mastectomy, and then 50 years ago, we were doing more and more lumpectomies. And then in the 90s, everybody was getting scared, so it was swinging back to double mastectomies. And nowadays, we're talking about, you know, hidden scar surgery, oncoplastic reconstructions. So we're seeing the pendulum sort of swinging back now to lumpectomies, where we're doing lumpectomies and plastic surgery, and really allowing women to keep their breasts and actually be treated equally as well as having the more radical full mastectomies.
Dr. Morrison, so we're not treating more, we're treating smarter.
Absolutely, and longer. So as Dr. Sanchez said, our patients are surviving longer and surviving better. So I also will remain in business because my disease is becoming a chronic issue. So I hope for the day when I say to a patient, what are you taking for your blood pressure? What are you taking for your diabetes? What are you taking for your breast disease? And we just keep managing and monitoring.
So I think it's very hopeful. I want to thank our panelists. I think the bottom line here is breast cancer diagnosis is not a death sentence. More and more women are surviving it. Therapy is less and less, if not invasive, less damaging, if you will, to the patient. But the important thing is healthy lifestyle, get that early screening, early detection, and you'll survive it. Thank you.